Welcome back to the Deep Dive, the place where we take massive textbooks, stack up complex research, and extract the high-yield, actionable knowledge you need. We're here to give you that competitive edge in mastering the foundational material of your field.
Today, we are moving past the philosophy and the underlying pathophysiology of disease, and we are plunging directly into the craft of surgery.
And for that, our source material is the absolute bedrock of surgical education.
It is. We're talking about Chapter 7 of the Baily and Love 28th edition, titled Basic Surgical Skills.
Okay, so let's unpack this. We spent a lot of time on theoretical frameworks, but this chapter is different. This is the blueprint, right, for actual technical competence.
It is. It defines the difference between just, cutting and operating with real meticulous skill.
It seems to cover everything. I mean, from managing nerve damage risk while just positioning the patient, all the way through to choosing the right suture.
It is the absolute foundation. And while we're, deep diving into the technical side today, the real nuts and bolts, the source material is very quick to emphasize that technical skill alone isn't enough.
Right. It has to be complemented.
Absolutely.
Yeah.
It has to be seamlessly complemented by all those non-technical skills. Stellar communication, efficient teamwork, critical situational awareness, and, above all, sound surgical judgment. This chapter teaches you the technique that allows that judgment to be safely executed.
So our mission today is pretty clear. We're going to interpret this core chapter, make it easier to absorb and recall.
Think of this as your ready reckoner, maybe a high-yield revision guide. It's aimed at maximizing your understanding.
But, and we have to stress this is an interpretation.
Yes, we strongly encourage you, the listener, to still go read the chapter in full for the complete, intricate picture and all the necessary anatomical detail.
To help with that absorption, we're going to be providing specific anchors and metaphors.
Right. These are designed to link these complex technical steps to, memorable rules or clinical scenarios, just to help solidify the details that often determine success or failure.
Okay, let's begin at the absolute starting line. It's a step that's so easy to overlook when you're imagining all the drama of the operating theater, patient positioning and safety.
This stage, it's often seen as just prep, but it's a profoundly critical moment. It requires extreme vigilance.
You're talking about the patient transfer and then getting them positioned on the table.
Exactly.
Yeah.
And often the patient is already under anesthesia.
Yeah.
It is a really high-risk activity. The immediate hazards are, falls, soft tissue injuries, and alarmingly preventable nerve damage.
I understand the risks of a fall, but talk to me about the process. Who's in charge here? Who coordinates that move?
Well, it's a shared team responsibility. It involves the surgeon, the scrub nurse, the circulating nurse, the ODPs.
So everyone.
Everyone.
Yeah.
But because the patient is intubated, the anesthetist is typically the central coordinator. They're managing the airway, ensuring the cervical spine is stable.
And they call the count.
They're usually the one who calls the count, yes. That coordinated command to initiate the simultaneous movement of the patient from the trolley to the table.
And this coordination is especially vital for certain patient groups, I imagine.
Oh, absolutely. Patients at the extremes of age, so pediatric or geriatric patients, they're fragile. The severely obese or, the profoundly emaciated, they have unique pressure point risks.
So they need specialized padding.
Specialized foam padding, positioning aids, the whole works. Ignoring those specialized needs just dramatically increases the risk of injury.
When we talk about positioning, it's not just about getting the patient into a convenient spot for the surgeon.
Not at all. There are 4 essential and sometimes competing objectives that have to be met at the same time.
Okay, so let's group these 4 objectives under an anchor. Let's call it the ergonomic cockpit. This whole setup determines the safe launch and successful completion of the entire mission.
That's a powerful metaphor, because if that cockpit isn't right, the mission is compromised from the start.
So objective number 1.
First, you have to facilitate safe anesthesia and safe surgery. That means the airway is accessible and the surgical field is exposed. Second, reducing adverse physiological insults. So minimizing the strain on the patient's internal systems.
And third is about the team.
Right. Optimizing surgical exposure and ergonomics for the surgical team. You don't want them forced into these unnatural, fatiguing positions for hours.
And the fourth objective, which really speaks to holistic care,
is maintaining the patient's dignity, making sure they're not unnecessarily exposed or left in uncomfortable positions for longer than is absolutely necessary.
And before any of this dramatic tilting or positioning happens, there's a checklist.
A pre-positioning check, absolutely. The operating cable has to be verified for function. All the accessories, arm boards, stirrups, supports, they have to be securely locked. You also need to map out where all the other equipment is going.
Like the laparoscopic stacks, the diathermy plate.
Diathermy plate, warming blankets, everything. And this brings us right to that inherent conflict in the objectives. You have to find a compromise between perfect surgical exposure, which can mean extreme angles, and what is, physiologically permissible.
That's the key phrase, isn't it? Physiologically permissible.
It is. For instance, you might want a really steep tilt for pelvic access, but if that tilt causes a critically ill patient to acutely decompensate.
Maybe their blood pressure drops.
Exactly. Severe venous pooling, hypotension, or it exacerbates a pre-existing respiratory problem, well, then you violated that second objective. The ideal position is always the safest position, not necessarily the most expedient one.
So the supine position is our baseline, the standard for most general procedures. Arms by the side or out on arm boards.
Right, and you have standard modifications. Rose's position, which is a slight extension of the neck for certain head and neck procedures, keeps the head stable.
And then we get into the dynamic shifts. For the two main tilts in abdominal work, let's use the tilt table. So we're talking about Trendelenburg and reverse Trendelenburg.
Right. Trendelenburg is the head-down tilt. Gravity pushes the abdominal viscera, the bowel up towards the diaphragm.
Which is invaluable for pelvic procedures, things like a prostatectomy or a low anterior resection. It just gets the small bowel out of the way.
It does. And it's also the traditional, though it's a bit debated now, position for resuscitating a patient in shock. The idea is to auto-transfuse central blood volume.
And the opposite of that is reverse Trendelenburg.
Head up, feet down. This time, gravity pulls all the abdominal contents down, away from the chest. This dramatically improves your exposure in the upper quadrants.
So for things like a laparoscopic fundoplication, liver surgery, a splenectomy.
Anything near the diaphragm, yes. It just clears the field beautifully.
And the source material really highlights the intense demands of advanced laparoscopy. You're seeing these exaggerated, really frequent position changes.
Oh, absolutely. You might be asked to tilt the table sharply right for left colon mobilization, and then literally moments later, switch to a steep Trendelenburg for the pelvic dissection.
And that kind of dynamic movement demands maximum security.
This is where proper securing techniques become, frankly, life-saving. So where specifically does that safety belt go?
It has to be placed 5 centimeters above the knee, and crucially, never across the abdomen.
Never. It could compromise their breathing or even vascular supply. And for those severe angles, you need specialized supports. Shoulder supports are mandatory for Trendelenburg to stop the patient from sliding right off the table.
Side supports for tilting, foot supports for reverse Trendelenburg.
Right. Though the highest safety measure involves those specialized vacuum-activated positioning systems, they just mold to the patient and distribute the pressure so evenly.
But positioning is just. It's fraught with potential for nerve injury, isn't it? Especially in the arms.
It is. Let's talk about the primary anchor for preventing brachial plexus damage, the 90-degree rule.
This sounds fundamental.
It is a fundamental safety mechanism that has to be drilled into every single trainee to minimize the risk of attraction neuropraxia on that delicate brachial plexus, the arm's angle of abduction.
So how far it's extended out from the body?
Exactly. It must be limited to less than 90 degrees. If you go past that angle, you put undue tension on that nerve bundle as it passes under the clavicle.
And it's not just about the angle of abduction. The rotation of the arm matters as well?
Absolutely. If the extended arm is pronated, so the palm is facing down, that action alone can increase traction on the brachial plexus. And on top of that, it risks direct pressure on the ulnar nerve at the elbow.
The funny bone palsy.
A temporary or even permanent funny bone palsy, yes.
Yeah.
Beyond nerve damage, you also have to worry about pressure necrosis, especially over bony prominences like the heels, the sacrum, the elbows, and the scalp during long procedures.
And let's go back to the physiological impact. We mentioned respiratory compromise from steep Trendelenburg, but what else are we monitoring?
We are critically monitoring for raised intracranial pressure, or ICP, and intraocular pressure, IOP.
Why is that?
Well, the head-down tilt causes venous congestion in the cranium and in the retina. This can be really dangerous for patients with pre-existing glaucoma or, say, a space-occupying lesion in the brain. The whole team has to be aware of these internal, less visible risks.
The risks just multiply when we move into other positions, like the prone position, lying on their stomach.
Right. This is mandatory for spinal procedures or specialized pelvic procedures like the extralater abdominoperineal excision.
And the process of getting the patient prone is meticulous.
It is. They're often intubated while they're supine and then log-rolled by a coordinated team of at least 4 people. The absolute key safety measure here is placing axillary and lateral chest rolls.
Okay, why are those rolls so essential?
They are completely non-optional. They lift the chest off the hard table surface, which lets the abdomen hang free.
Wow.
But this prevents pressure on the vena cava, which helps venous return, and most importantly, it lets the chest wall and diaphragm move without being impeded.
Which facilitates proper breathing.
Proper respiration, and it prevents a VQ mismatch.
What's the most severe, though rare, complication of getting the prone position wrong?
Well, beyond brachial plexus injury and shoulder dislocation, the source material emphasizes facial trauma and, crucially, blindness.
Blindness.
Blindness secondary to ischemic optic neuropathy. It's caused by prolonged, uninterrupted pressure on the eye or by vascular congestion that prevents adequate perfusion. Proper head positioning, using specialized pillows that keep the orbits free of pressure, is paramount.
Next up is the lateral position, used for things like a thoracotomy or accessing the retroperitoneum. And there's a common modification, the kidney position.
Right, where the table's broken or angulated in the middle. That angulation increases the space between the 12th rib and the iliac crest, so it gives you wider access for retroperitoneal or urological work.
And the safety points here seem tricky.
They are. The lower arm is extended and padded. The upper leg is usually flexed more aggressively, with padding between the knees to stabilize the position and prevent pressure on the lower limb.
And again, head placement is critical. This brings us to our first check-in question for you, the listener, to really cement these complex physiological concepts. Check-in question. If a patient needs a long procedure in the lateral position, what specific positioning adjustment must be made for the head, and what is the primary respiratory risk associated with this long-duration tilt? Take a moment to think about the airway.
If you didn't get it instantly, just rewind and listen again to the points in physiological risk. The answer really relies on understanding how gravity affects a tube in the trachea.
The correct answer is cervical alignment must be maintained to prevent nerve injury and ensure an even airway. The primary respiratory risk is endobronchial migration of the endotracheal tube.
Right. Gravity or just movement can cause that tube to slide down into one of the main bronchi,
Which leads to preferential ventilation of only one lung, and that causes significant sudden oxygenation issues.
Finally, we have the lithotomy or the modified Lloyd-Davies position. This is for gynecological, perineal, or colorectal procedures with the patient's legs flexed up in stirrups.
The safety instructions here are surprisingly specific and unforgiving.
They are. Both legs must be placed in and removed from the stirrups simultaneously. If you don't, you can cause a severe torsion injury to the pelvis and spine.
And there is a really explicit and frankly grim warning in the source material.
Yes. The patient's fingers must not extend past the edge of the operating table. They risk being accidentally crushed or even having a digital amputation when the table sections are moved or locked.
And the complications of the lithotomy position are severe.
Very. Prolonged pressure or excessive abduction and external rotation can lead to limb ischemia and a subsequent compartment syndrome, a truly catastrophic outcome. You also risk sciatic or peroneal neuropraxia from pressure against the stirrups or the hard table. It's a position of necessity, but one that demands extreme vigilance.
Okay, let's move from patient safety to sterile safety. Our next major objective is mitigating surgical site infection, or SSI.
Right. And the initial step, before you even think about skin prep, is meticulous. You need to check for and remove all rings, piercings, and any metal foreign bodies, especially in or near the operative field.
And there are two main reasons for this.
There are. Firstly, metal can act as a potential reservoir, or nidus, for bacteria. It just increases the infection risk. Secondly, and maybe more acutely, any piece of conductive metal can act as an unintended return path for the electrical current if you're using diathermy.
Causing a burn.
A severe thermal injury or burn at that contact point. And on top of that, postoperative edema makes removing rings really difficult, and that risks digital vascular compromise.
Next up, hair removal. The textbook is really clear on two things: when and how.
Hair is only removed if it is genuinely thought to interfere with the operation or applying dressings.
Yes.
If you do need to remove it, the ideal time is on the operating table after the patient has received their prophylactic antibiotics.
Why after the antibiotics?
To ensure the highest level of sterility when you inevitably create microabrasions. Preoperative removal outside the OR is actively discouraged because those little cuts have time to get colonized by bacteria.
And the method is anchored firmly as clippers Not razors. Why is that distinction so important?
Well, the clinical data on this is really robust. Razor shaving creates these microscopic nicks and cuts that lead to exaggerated skin inflammation and significantly increase the risk of cellulitis and SSI.
So clippers are safer?
Skin clippers with disposable blades just shear the hair above the skin. They are consistently shown to result in the fewest SSIs. It's a non-negotiable step in modern surgical practice.
Okay, so hair is handled. Now we move to chemical antisepsis. What's the preferred solution today?
Alcohol-based antiseptic solutions are the standard. The alcohol provides rapid and potent bactericidal action. While povidone iodine alcohol is acceptable, the WHO often favors chlorhexidine alcohol.
But the alcohol is the key component.
The alcohol base itself is the critical component, yes. The clinical difference between the two alcohol-based solutions in preventing SSI seems to be pretty marginal.
And the application technique changes depending on how contaminated the wound is presumed to be.
It does. For a clean elective procedure, the movement is centripetal. You start at the center, the planned incision site, and you move concentrically outward toward the periphery. And you don't return to the center with a used sponge.
But if the wound is dirty, say draining an abscess or a traumatic injury, you reverse that.
Precisely. You have to move from the area of lower contamination, the surrounding clean skin, toward the region of greater contamination, which is the center of the pus or the dirty part of the wound. This stops you from dragging pathogens across the clean field.
We mentioned the fire hazard with metal objects, but the skin prep solution itself introduces a huge risk.
A critical safety note. You have to allow the alcohol-based solution to dry completely before any electrical equipment is activated. If that solution pools under the patient or near the diathermy plate, the volatile alcohol can ignite.
And those flames can be hard to see.
They can be nearly invisible in the bright aura lights, and they lead to severe, often devastating burns. This rule is absolute.
Finally, we drape the patient, creating the sterile perimeter. The drapes should be high quality.
Fluid-resistant, flame-resistant, anti-static, and lint-free. And two practical points are emphasized here. First, avoid sharp towel clips if you can. They pierce the drapes and create a pathway for bacteria.
Breaching the sterile barrier?
Exactly. If you even suspect a breach of sterile technique, say a drape touches the floor, it has to be immediately discarded or securely covered by a new intact drape.
Now, what's the verdict on those transparent adhesive drapes we often see?
That's a bit of a controversy. It's important for trainees to know that the routine use of transparent adhesive skin drapes, even the ones impregnated with antibiotics, is not supported by the current literature to significantly reduce SSI rates.
They can actually be a problem.
They can sometimes trap moisture underneath, which can lead to colonization, so they should be used selectively, not just as a matter of routine.
Okay, we now enter the physical act of surgery, the incision, the surgeon's first statement of intent.
And it requires precision, not brute force. The textbook says the scalpel should be pressed firmly, held at a right angle, and drawn gently.
That right angle seems fundamental.
It's fundamental to wound healing. Holding the scalpel at a right angle ensures that the entire edge of the cut is clean and perpendicular to the skin. If you cut obliquely, you create a shearing mechanism.
You undercut one edge more than the other.
Right. And that results in this ischemic, thin flap of skin that has a higher risk of necrosis, poor healing, and an unsightly scar.
And there are safety elements for the surgeon stressed here, too.
Yes. Tension on the skin should be applied by the non-dominant hand, stretching it across the line of the incision. But the scalpel must never, ever be directed toward the surgeon's own fingers.
And passing scalpels.
Always use a kidney dish or neutral zone. Never hand to hand. It's a key protocol to prevent sharp instrument injuries.
When it comes to selecting the blade, we match the tool to the task. What are the common choices?
The standard workhorse for a large abdominal incision is the 22 blade. It has a long, curved cutting margin, but for specific, sharp entry tasks.
Like an arteriotomy or draining an abscess.
Exactly. For those, or for establishing a drain tract, the sharp-tipped 11 blade is preferred.
Let's move from technique to planning. Incision planning seems to involve geometry, anatomy, and functionality, starting with cosmesis.
We've seen a necessary shift in cosmetic planning. We're moving away from the historical but anatomically rigid Langer's lines.
Which maps static collagen.
Right. We're moving toward the concept of relaxed skin tension lines, or RSTLs. These follow the natural creases formed when the skin is pinched and relaxed, usually perpendicular to the muscle pull. Incising along these lines allows for a tension-free closure that better camouflages the scar.
But the other considerations can override cosmesis.
Oh, absolutely. While avoiding critical anatomy like nerves and large vessels is essential, the third consideration is paramount. Adequate access for the procedure is non-negotiable.
So if you need wider access to be safe, cosmetics take a backseat.
They have to. Compromising functionality purely for cosmetic reasons is dangerous surgical practice.
Now, if we're excising a lesion, like a lipoma or a melanoma, we're told to use elliptical excisions over circular ones for a better closure. And this is governed by an easy-to-remember principle.
The 3.1 rule.
Explain that.
The 3.1 rule dictates the geometry of the ellipse. The length of the ellipse must be at least 3 times its width. If you make it too short relative to its width, when you try to close it, you'll invariably create dog ears.
Those little puckers of tissue at the corners.
Exactly. And they require a secondary, careful excision, lifting the tissue with a skin hook and excising the excess to get a flat, aesthetic final closure.
Let's focus now on open abdominal access, the gold standard for emergencies, the midline laparotomy.
The midline approach is still the preferred incision in acute emergency settings. It's the quickest to perform, and it offers the greatest versatility for accessing pretty much the entire abdominal cavity.
Which is key when the diagnosis is uncertain.
Absolutely.
Now, we touched on this controversy earlier, scalpel versus electrosurgical diathermy for the incision.
The source material is quite balanced on this. Large comparative studies show no significant difference in hard outcomes like SSI, wound dehiscence, or blood loss when you compare the two.
So why would a surgeon choose diathermy then?
It often comes down to surgeon preference and one potential minor benefit. There's some data suggesting that incisions made with diathermy may result in a lower need for postoperative analgesia.
Maybe from cauterizing small nerve endings.
That's the theory. Also, in very vascular or highly contaminated fields, diathermy gives you immediate microhaemostasis, which improves visibility. But if time or cost is a factor, the scalpel is still perfectly safe and effective.
And we also have to compare transverse versus longitudinal incisions.
Right. Transverse or oblique incisions, like a Kocher's subcostal, they cause less pain postoperatively because they follow the lines of muscular pull. They also lead to better pulmonary function and, importantly, significantly fewer incisional hernias long-term.
But they must have some limitations.
They do. They offer more limited access compared to a long midline incision, and some conflicting data suggests they might have a slightly higher SSI risk. It's a trade-off between long-term durability and immediate access.
Let's detail the steps of that midline laparotomy incision, focusing on the anatomy.
Okay, we start with the skin incision, using landmarks like the xiphisternum, the umbilical cicatrix, which is just the scar tissue of the belly button, and the pubic symphysis. Skin first. Next, we dissect the subcutaneous tissue down to the rectus sheath and the linea alba.
That fibrous midline.
That's the one. And the third step is key, incising the linea alba. It's done longitudinally, but importantly, it has to be incised close to the umbilical cicatrix, where it's often thinner and more predictable.
And you have to avoid straying laterally.
You do. That would mean incising the rectus sheath itself or damaging the superior and inferior epigastric vessels.
And what follows that?
Dividing the preperitoneal fat. Then, the peritoneum is carefully picked up between two hemostats. This is a critical safety step. The two clamps are lifted high and shaken slightly to ensure no underlying viscera, like a loop of bowel, are caught between them.
And only then do you open it.
Only after you confirm nothing is caught between the clamps do you open the peritoneum with scissors, using your fingers as internal protectors while you extend the incision.
A very different challenge comes up during re-entry incisions when a patient has a previous scar.
The guiding principle here is to avoid railroading. So, creating a new incision that crosses the old one, that compromises blood supply and risks skin necrosis. It's better to either excise the old scar or cut directly through it.
But the really critical safety instruction is about entering the abdomen.
Yes, you must extend the incision past the visible old scar to enter the peritoneal cavity at a virgin plane.
Why is that so important?
Because old scar tissue underneath often has bowel or omentum just intensely stuck to it. Trying to enter through that plane is a massive risk for an enterotomy or bowel injury. Entering virgin tissue ensures you're encountering normal anatomy. It gives you the greatest safety margin.
Okay, let's shift to minimally invasive access. Laparoscopic port placement. We have two core approaches. Open, which is Hassan's, and closed with a Veris needle.
For general laparoscopic work, the safety profiles of both are pretty comparable. A skilled laparoscopic surgeon needs to be proficient in both methods because the clinical scenario often dictates the choice.
Like in patients with previous surgeries?
Exactly. The open approach is often preferred in patients with multiple previous surgeries or in pregnancy.
So focusing on the open Hassan's technique for that primary port, usually at the umbilicus.
The procedure starts by everting the umbilical cicatrix with forceps. This is usually adherent to the underlying fascia. A curved incision is made below it, the fibrous stalk is exposed, and then comes the crucial step.
The fascial incision.
A small, vertical 5 mm incision through the fascia. The surgeon then carefully dissects through the preperitoneal fat.
And how do you confirm entry?
A blunt instrument, often a haemostat, is gently pushed through the peritoneum until the surgeon feels a distinctive pop or a loss of resistance. That confirms entry. Only then is the blunt-tipped Hassan trocar inserted and secured, followed by careful CO2 insufflation, usually to a max of 15 mmHg.
And what if the umbilical area is just compromised from previous surgery?
The standard alternative is Palmer's point. It's located 3 centimeters below the left subcostal margin in the midclavicular line. Anatomically, this spot is generally considered safer than other sites when umbilical access is risky.
Now for the varus needle technique, the closed approach. This relies on that spring-loaded safety stylet.
Right, which is designed to retract and prevent injury once the tip passes through the dense peritoneal layer. Insertion is done carefully, often with the abdominal wall lifted. Once it's in, you have to confirm you're in the right place. We can anchor this confirmation protocol as the 3 proofs.
Okay, proof number 1.
The hanging drop method. A drop of saline placed in the hub of the needle should be sucked into the abdomen when you lift the abdominal wall because of the negative pressure you create.
Proof number 2.
Free flow of saline into the cavity from a syringe, and importantly, no return of blood or bowel contents when you aspirate back.
And proof number 3.
Once you start insufflation, the pressure reading on the insufflator has to stay low, less than 10 mmHg2. If it's high, the needle is misplaced in the preperitoneal fat or it's up against something solid. Only when those 3 proofs are confirmed do you start high-flow insufflation. Secondary port placement requires equal, if not greater, vigilance. All secondary trocars must be inserted under direct camera vision to avoid devastating injury to vessels, bladder, or bowel.
And they should be inserted perpendicularly.
Perpendicularly to the abdominal wall to minimize fascial trauma and optimize surgeon ergonomics.
And to avoid the most commonly injured vessel, the inferior epigastric artery, we use another essential anchor, the hand's breadth rule.
The rectus sheath, which contains those epigastric vessels, extends roughly the width of a patient's hand's breadth on either side of the midline. So non-midline trocars should be placed lateral to this boundary to safely avoid them.
And the size of the port also dictates a mandatory safety step during closure.
Yes. While smaller trocars are great for cosmesis and pain, all quart sites greater than 5 mm in diameter require meticulous suture closure of the fascial layers to prevent a port site hernia.
And the last step.
Always remove all trocars under direct vision to confirm there's no bleeding, particularly from the port site itself.
We've established exposure and completed the procedure. Now comes closure, a section that's often underestimated but is so critical for the long-term outcome. Before we pick a stitch, let's just briefly set the stage with the types of wound healing.
This is foundational biology. There are 3 types. Primary intention is the goal for clean surgical wounds. The edges are approximated and sutured together,
Allowing for rapid healing with minimal scarring.
assuming there's no infection or tension. Yes. Then you have secondary intention. This is for wounds that are deliberately left open. Maybe they're heavily contaminated or have significant tissue loss.
And how do they heal?
They heal slowly from the base up. The defect fills with robust granulation tissue, a mix of new blood vessels and collagen, followed by wound contraction and epithelialization. This results in a wide, noticeable scar, but it's necessary for compromised tissue.
And then there's the subtle but clinically vital middle ground, tertiary intention or delayed primary closure.
This is a critical decision-making step. Tertiary intention is chosen when the wound is highly suspicious for infection, say a traumatic abdominal wound, where the risk of deep infection is just too high for immediate closure.
So you leave it open for a few days.
You leave it open, often packed, for 3 to 5 days. If, after that time, the wound looks clean and healthy, the surgeon will then return, debride it slightly, and close it primarily. It lets the body manage the initial bacterial load.
Okay, let's get into the material itself. Suture material selection is almost an art form. We have to distinguish between structure and strength.
Structurally, we differentiate between monofilament and multifilament, or braided, sutures.
Monofilament sutures are single strands. They glide through tissue easily, which causes less tissue drag. But what's their primary drawback with knot security?
They are notoriously difficult to knot securely. Because they're smooth and stiff, they want to slip. They require extra throws up to 6 to secure a reef knot. And they're fragile. If you clamp them too tightly, they can fracture and lose their strength.
And multifilament or braided sutures are the opposite.
They're excellent for knotting. They're soft, they have a high coefficient of friction, so the knot beds down tightly and stays secure with fewer throws.
However,
Because they're braided, they have a large surface area and tiny gaps between the strands. This gives them a powerful capillary action, which allows bacteria to wick along the strand.
potentially leading to persistent infection or suture sinuses.
Exactly. Silk is the classic example.
Strength retention is the next critical factor. The suture has to last long enough for the tissue to heal.
But not so long that it becomes a permanent foreign body. And the strength retention varies wildly. Catgut is almost useless after a week. Delayed absorbable synthetics, like PDS, they retain significant strength for several weeks.
Making them ideal for fascia closure.
Right. And for non-absorbable materials, synthetics like polypropylene retain their tensile strength indefinitely. This is necessary for vascular grafts. But a non-absorbable biological material like silk, it fragments over time and loses its strength. So it's inappropriate for high-pressure vascular anastomoses.
Let's move to needle selection. We've advanced to eyeless or atraumatic needles. We categorize them by their point.
We have round-bodied or tapered point needles. These are designed to separate tissue fibers without cutting them. They're mandatory for delicate structures like bowel or vessels where you want to avoid bleeding.
And then we have cutting needles.
Cutting needles, conventional or reverse cutting, have sharpened edges to slice through tough tissues. These are for dense layers like skin or fascia.
And the increasingly common blunt-ended needles.
These are used primarily for closing the abdominal wall. Their dull tips significantly reduce the risk of needle stick injuries to the surgical team, but they still have enough force to pass through fascia.
Okay, let's discuss the 4 primary suture techniques, starting with the workhorse. Interrupted sutures.
Interrupted sutures are inserted individually, tied, and cut. They distribute tension locally and provide the most security, since if one knot fails, the others are fine.
And there's a rule for placement.
There is. The distance from the edge of the wound should equal the depth of the tissue being incorporated, and each subsequent stitch should be placed at about twice that distance apart. This ensures proper tissue approximation.
Next, continuous sutures.
Continuous sutures are much quicker. They distribute tension evenly along the whole wound. They're secured at the beginning and the end, often with a specialized Aberdeen knot. The challenge is maintaining tension. An assistant has to follow the suture line, gently pulling the slack away.
Then we have mattress sutures, vertical and horizontal.
These are used strategically. They're designed for accurate tissue approximation, and they're excellent for deliberately achieving either aversion, tuning the edges outward, which you want in skin, or inversion, turning them inward, which you want in bowel.
Finally, the subcuticular suture.
The choice for maximum cosmesis. It takes small bites of the tissue layer just beneath the skin. If it's done correctly, it avoids placing any sutures across the skin surface, so you don't get those cross-hatched scars.
And if you use an absorbable material, the knot can be buried.
Exactly. No need for suture removal at all.
Regardless of the technique, the whole closure hinges on the knot. Poor knotting just ruins all the careful work.
The principles are universal. The knot has to be tied firmly, but without strangulating the tissue and causing ischemia. It has to be as small as possible to minimize foreign body reaction. And critically, it must be laid down square. A granny knot will slip.
The standard is a reef knot with 3 throws.
But up to 6 for a slippery monofilament. And you can use a surgeon's knot for added security under tension. The cut end should be left 1 to 2 millimeters long to prevent them unraveling.
Okay, let's get to the greatest closure controversy. Closing the abdominal wall fascia, the rectus sheath or linea alba. This is the layer that prevents hernias.
This is where local tradition often clashes with modern evidence. The standard practice is a continuous suture line, often with the delayed absorbable monofilament like PDS. The debate is about how you apply that suture.
The debate is big bites versus small bites. We've all seen older surgeons teach taking large 1 centimeter deep bites 1 centimeter apart. What does the source material say about that? And what exactly is the failure mechanism, the famous anchor? The cheese wire effect.
That is the core conflict. Recent meta-analyses and trials strongly support the small bites technique. This means reducing the spacing to about half a centimeter, taking smaller tissue bites, and often using a smaller gauge suture. This has been shown to significantly decrease the rate of incisional hernia.
So why does the 1 centimeter by 1 centimeter method fail?
The cheese wire effect is the perfect visualization. If you use a large needle, you create a large buttonhole-like defect in the fascia. When you combine that large hole with wide spacing, any increase in intra-abdominal pressure postoperatively, a cough, a sneeze, causes that suture to act exactly like a cheese wire.
It just cuts through the fascia between the stitches.
It cuts through, leading to rapid suture slackening, fascial edge separation, and inevitable hernia formation. The small bites technique minimizes the fascial defect and distributes the tension over more points, preventing that cut-through failure.
That distinction alone makes this deep dive invaluable. Finally, when do we remove non-absorbable sutures? This is governed by the location, which we can call the anatomical clock.
You're balancing two risks. Removing them early minimizes the scar and infection risk. Removing them too late risks the wound splitting open. So the timing is location dependent.
The face and scalp heal fastest.
Excellent blood supply. You can take those out at 3 to 5 days. The neck falls at 5 to 7 days. The abdomen, under the greatest tension, needs the longest support, usually 10 to 14 days. And that timing has to be explicitly stated in the patient's notes.
Okay, moving on to stopping the bleed. Haemostasis and electrosurgery. The source material categorizes hemorrhage not just by volume, but by its timing.
We classify 3 types. Primary hemorrhage happens during the operation itself. Then you have reactionary hemorrhage, which occurs postoperatively, typically within the first 24 to 48 hours.
What causes a reactionary bleed?
It's often a vessel that was missed or seemed securely tied during the operation, but it was severely vasoconstricted because the patient was hypotensive or cold. Once their vitals normalize, their blood pressure rises, the vessel dilates, and the bleeding starts. A slipped ligature is another common cause.
And the most concerning type, the delayed bleed.
Secondary hemorrhage. This occurs days or even weeks after the procedure, and this is almost always a sign of deep-seated infection. The infection creates an inflammatory environment that just erodes into the wall of a large blood vessel.
The fundamental rule of hemostasis is always stressed. Avoid plunging clamps blindly into pools of blood. Why is the textbook so against this?
Because blind clamping is far more likely to cause severe collateral damage, injuring an adjacent nerve, artery, or ureter, than it is to solve the problem. The priority is to evacuate the blood pool, apply gentle pressure, identify the bleeding point, and secure it meticulously.
And prevention is key.
Preoperative optimization of antiplatelets and anticoagulants is the best prevention.
Among all the tools, electrosurgery is the dominant thermal tool. Let's revisit the principles.
Electrosurgery relies on high-frequency alternating current. If we use the standard wall frequency of 50-60 Hz, you'd get violent muscle contractions and electrocution. So the electrosurgical unit, the ESU, converts that current to a very high frequency, 500,000 to 3 million Hz, to bypass the neuromuscular system and just convert the energy into heat.
We have monopolar and bipolar diathermy. Monopolar is the standard surgical pen.
In monopolar, the current flows from the small active electrode through the patient's entire body and returns to the generator via a large dispersive plate. The risk is all about the concentration of the current. If that plate is faulty, the current seeks other paths, leading to burns.
Bipolar, by contrast, is much safer for sensitive areas.
Yes. In bipolar surgery, the current flows only between the 2 prongs of the forceps. Only the small amount of tissue held between them heats up. This makes it ideal for areas near sensitive nerves, like the recurrent laryngeal nerve during a thyroidectomy, or for patients with pacemakers.
Diathermy can produce 2 effects, cutting and coagulation. What separates the physics of these two?
The distinction is in the voltage and the waveform. Cutting uses a lower voltage and a continuous waveform. The current is delivered so intensely and rapidly that the tissue water instantly vaporizes, exploding the cells. This results in a clean incision with minimal lateral thermal spread.
And coagulation?
Coagulation uses a higher voltage but an interrupted waveform. The current is cycling on and off. This slower, gentler heating dehydrates the tissue and denatures the proteins, causing them to clot and seal. But because the heating is slower, there's extensive lateral thermal spread.
Given the reliance on electricity and heat, diathermy has inherent risks. Let's run through the crucial hazards under our diathermy safety checklist.
Burns are the most common complication. They happen when the current finds an unintended small surface area return path. The causes are multiple: faulty dispersive plate contact, the patient touching a grounded metal object, faulty insulation, or accidental activation.
Then there's the risk of explosion.
This usually links back to the skin prep we talked about. If pooled alcohol prep is ignited by a spark, you get a flash fire. Also, certain intestinal gases can ignite if the bowel is opened, and diathermy is used internally.
And the unique hazard of channeling.
Channeling is the bottleneck effect of current concentration. If you apply monopolar current to a tissue stalk with a very narrow base, like the spermatic cord in a child, the current concentrates as it exits the narrow area, causing unintended, massive collateral damage.
So in those cases, bipolar is mandatory.
Bipolar diathermy is absolutely mandated in those narrow stalk scenarios to prevent catastrophic injury.
And in laparoscopic surgery, the visibility issues just multiply the risk.
They do. Laparoscopic injuries can happen when insulation on the instrument fails, letting current arc to bowel outside the camera's view, or through direct coupling, where the active electrode touches another metal instrument, tuning that second instrument into a live electrode.
This complexity and risk really drove the development of advanced vessel sealing devices, didn't it?
It did. They're designed to safely close vessels up to 7 millimeters in diameter. We have two primary technologies. First, advanced bipolar fusion, like ligature. This system applies both controlled pressure and radiofrequency energy to literally fuse the tissue layers together.
What makes them so robust and safe?
The key is the integrated feedback sensing technology. The device actively monitors the electrical impedance of the tissue between the jaws. It automatically adjusts and stops the energy the precise moment a secure seal is achieved.
Removing the surgeon's reliance on just tactile feedback.
Exactly. It creates a seal that can reliably withstand up to 3 times normal systolic blood pressure.
The second technology is ultrasonic energy devices, like the harmonic scalpel.
This uses a completely different physical mechanism. It cuts and seals via high-frequency vibration. The friction denatures protein and achieves haemostasis without the large thermal spread of traditional diathermy. The benefits include less smoke, which improves visibility, and better cutting through dense tissue.
These advanced devices sound almost mandatory, given their safety benefits. But does the source material address the economic reality? I mean, using a ligature for every small vessel might be cost prohibitive in some places.
That's a highly relevant practical point. While the textbook focuses on the technical superiority, the reality is that these are expensive disposable items. The decision to use them is a clinical calculation weighing cost against time savings and superior safety assurance, especially in critical areas like thyroid surgery, where precision is non-negotiable.
So in some settings, manual ligation is still the standard?
In high-volume, resource-constrained settings, manual ligation remains the economical and effective standard for smaller vessels. Technology enhances safety, but economy of means is still a core surgical skill.
Okay, let's turn to the controversial final step of many procedures, surgical drains. Lawson Tate's famous dictum was, when in doubt, drain. But modern surgery has heavily scrutinized that advice.
And for good reason. Drains serve the purpose of letting collections, blood, serum, pus, air exit the body. They can be placed prophylactically to anticipate a collection, or therapeutically to evacuate an existing one.
We classify them first by their mechanism of action.
We have open, passive drains, like the Penrose drain. They rely entirely on gravity and capillary action. The major drawback is that they create a direct conduit from the outside world into the sterile operative field, which greatly increases the risk of infection.
Which makes closed drains preferable.
Yes, closed drains can be suctioned or active, like Jackson Pratt drains. These apply negative pressure, sucking fluid out and obliterating dead space. Or they can be non-suctioned, passive closed systems that still use gravity, but without the active suction.
So let's tackle the controversy, Lawson Tate's dictum, head on. What are the modern arguments for routine prophylactic drainage?
Well, the protagonists argue that drains remove undesirable fluid collections, preventing hematoma or seroma. And they also serve as a crucial early warning system. If a drain suddenly outputs pure bile or stool, it signals a leak or hemorrhage.
But the detractors have successfully shifted practice away from routine use. What's their evidence?
Their arguments are compelling. Drains themselves increase infection risk by acting as a conduit for skin bacteria. They cause pain, they delay patient mobilization, and critically, they can give a false sense of security if the drain gets blocked.
A blocked drain shows zero output, but a collection could be building internally.
Exactly. A devastating collection.
So what's the current consensus? Where is routine drainage avoided and where is it still considered?
Routine prophylactic drain placement is now widely avoided in countless common elective procedures where it was standard a decade ago. Cholecystectomy, hernia repair, thyroid surgery. Grains are only considered routinely in high-risk procedures, where the risk of a leak or collection is high, like a radical neck dissection or major pancreatic resection.
Let's look at some specialized drains, starting with nasogastric tubes or NGTs.
Modern practice, heavily influenced by enhanced recovery after surgery, or ERS protocols, has caused a clear trend away from the prophylactic use of NGTs. Their use is now selective, managing an established obstruction or ileus or for feeding.
And the serious contraindications for placing one.
They are absolutely contraindicated with a suspected or confirmed base of skull fracture. Blind insertion risks passing the tube into the cranial cavity, which is a catastrophic outcome.
And finally, T-tubes, historically used in the common bile duct after exploration.
These were designed to provide controlled external drainage of bile. However, modern evidence, including Cochrane reviews, suggests that T-tubes are actually associated with increased bile leakage rates and longer hospital stays, with minimal benefit. Their use is now rare.
If one is used, how is it managed?
It requires a specific protocol. It has to stay in for at least 2 to 3 weeks to allow a fibrotic fistulous tract to form. Before removal, a T-tube cholangiogram is done to ensure the duct is patent and there are no leaks. Only then, after the patient tolerates a 24-hour clamping trial, is it removed.
The final critical decision is drain removal. This is our last anchor. Objective achieved.
This anchor stresses that drains have to be removed as soon as their stated purpose is fulfilled, not based on some arbitrary schedule or volume. If it's to monitor for hemorrhage, it's often removed in 24 hours. If it's draining an infection, it stays until the drainage is minimal.
What about drains placed near a fresh bowel anastomosis?
They're usually removed at 3 to 5 days. But the textbook emphasizes a vital concept for the trainee. A drain assists external drainage of a leak. It absolutely does not prevent a leak.
It just guides the contaminated fluid out.
Exactly, which is beneficial, but its presence didn't stabilize the anastomosis itself.
And the specific technique for chest drain removal is unique. It requires the patient's help.
Correct. When removing a chest drain, the suction is disconnected first. The patient is instructed to perform a Valsalva maneuver, take a deep breath in, and hold it, while the surgeon rapidly removes the drain. This high positive pressure prevents air from being sucked back into the pleural cavity. A pre-placed suture is then immediately tied down.
That was an intensive journey through the fundamentals of surgical craft. We started with positioning, the ultimate team exercise in safety, establishing the crucial anchor of the 90-degree rule to prevent brachial plexus injuries.
We cemented the principles of asepsis, confirming that clippers, not razors, are mandatory for hair removal to mitigate SSI risk, and we navigated the abdomen with the 5 meticulous steps of a midline laparotomy.
In the geometry of closure, we established the 3.1 rule for aesthetic elliptical excisions and learned to apply the hand's breadth rule to safely site laparoscopic trocars.
Most critically, we delved into the ongoing controversy of fascial closure, where the research strongly dictates the small bites technique to circumvent the cheese wire effect, which can lead to long-term hernia formation.
And finally, we covered modern technology, recognizing the safety advantages of advanced bipolar fusion devices like ligature with their feedback sensing technology, and we balanced this against real-world considerations of cost.
The source material is a magnificent testament to the blend of meticulous traditional craft and cutting-edge technology. But as you continue your clinical training, here's a final provocative thought to consider.
One that reflects on the implications of the technology we just discussed.
Right. The advancement of haemostasis devices, like ligature, has integrated automated feedback technology. The machine manages the energy and confirms a permanent seal for the surgeon. So as we become more reliant on the machine telling us the seal is complete, what non-technical skills related to tissue judgment, tactile feedback, and manual precision might erode?
That's a fascinating question about the intersection of craft and code. I mean, if the surgeon relies too heavily on the technology to make these critical judgment calls, what happens to that innate sense? The ability to feel and judge the subtle stiffness or pliability of tissue, that sense of what a good manual ligature feels like, is a skill that has to be consciously maintained even as the instruments get smarter.
The machine confirms the action, but the surgeon must always possess and exercise the judgment.
We hope this deep dive serves as an invaluable ready reckoner and revision tool, helping you solidify the concepts in Chapter 7 of Baily and Love. Go read the full text, and thanks for diving deep with us.